Hi, everyone. Good evening and welcome to the second of 3 webinars for the OATA demonstration project. Before I get going, I just wanted to remind anyone that if anyone was interested in signing up for the OATA golf tournament June 2nd, that if they do so by the end of this Friday, business day, they'll be entered into a draw for the BlackBerry Playbook, which is really exciting. So we got that. Now we're going to go on to the demonstration project at hand. My name is Sarah Rabinovich. I'm sure you'll recognize it from all the previous email communications we've had. Thank you for taking the time to join us this evening. To ensure we know who is logged in with us, if your name appears with only a first name, please take a sec to type in your full name. We will be going over the programs of care, or POCs, for both mild traumatic brain injuries and acute low back injuries, commonly referred to as MTBI and ALBI-ALB, respectively. If you haven't seen webinar 1, it's posted on the OATA website. It would be strongly recommended that you check that out at some point after this webinar to clarify any questions you might have. It is vitally important to the success of our data collection project and ultimately the demonstration project as a whole that the cases are selected appropriately and reports are completed accurately and submitted in a timely fashion. For the purpose of this evening's webinar, it is to review the inclusion and exclusion criteria for each POC, as well as the proper methods for completing the forms associated with the POC. The MTBI has been selected by the OATA for the demonstration project because, as athletic therapists, MTBIs fall within our scope of practice and are very much an area of expertise for us. This is also a current area of governmental and public interest, and thus extremely relevant to our clinical practice. In order for a patient to be included as a case in the demonstration project, there are several criteria that need to be met. The patients must be diagnosed with an MTBI. The requirements for that diagnosis will be reviewed in the next slide. The commencement of the treatment is to be no more than 1 year post-date of injury. The patients would present with head trauma. This can include a whiplash mechanism or a coup-contra-coup mechanism. Also included are patients who experienced a period of altered consciousness, remembering that loss of consciousness is not required. Patients should also have negative findings on all neuroimaging tests such as X-ray, MRI, etc. For the purposes of the demonstration project, a diagnosis of an MTBI requires at least one of the following: a loss of consciousness, a loss of memory of events immediately before or after the injury, an altered mental state at the time of the injury, or focal neurological deficits that may or may not be transient, but does not exceed 30 minutes loss of consciousness, an initial Glasgow Coma Scale score of 13 to 15 after 30 minutes, and post-traumatic amnesia of not more than 24 hours duration. So to sum that up, the patient needs to be diagnosed with an MTBI, as we just outlined, and fit the eligibility criteria as outlined in slide 3. Some patients won't fit the criteria to be eligible for the demonstration project. Patients that would be excluded for this POC are those with moderate or severe brain injuries and/or other injuries that may hinder the patient's expected ability to recover using the MTBI POC. Red flags would also include cancer of the cerebral CNS, one or more structural defects of the cranial vault. This would be found on neuroimaging tests, as we previously indicated would be an exclusion to the project. Also, any penetrating brain injury, any psychiatric disorder or psychopathology that would interfere or likely interfere with treatment, or any physical impairment or concurrent injury that would prevent proper assessment and treatment within the POC. Tools that will be utilized to assess the outcome measures are the Rivermead Questionnaire and the RAND 36 Item Health Survey. The Rivermead Post-Concussion Symptom Questionnaire is a simple one-page self-symptom evaluation questionnaire, not unlike the symptoms section of the SCAT-2. The RAND 36 Item Health Survey was designed as an outcome measure to evaluate 8 concepts as reported by the patient. These are physical functioning, bodily pain, role limitations due to physical health problems, role limitations due to personal or emotional problems, emotional well-being, social functioning, energy and fatigue, and general health perceptions. Both the Rivermead Questionnaire and the RAND 36 can be found on the OATA website's main page under the Programs of Care. Both of these questionnaires will be filled out upon assessment as well as discharge of the patient. Now we will go over the recommended treatments and interventions that are included within the MTBI POC. In the world of ATs, most of us are quite familiar and feel confident when working with patients who have sustained a concussion, or in this language, an MTBI. The POC outlines what most of us are already doing. The POC recommended interventions include education, cognitive rehabilitation, and manual mobilization therapy. The full outline of each POC is also available on the website. Same section as we mentioned before, so you can take your time to review the details of each inclusion, exclusion, outcome measure, and intervention. Let's go over some examples of what each recommended intervention entails to be sure that we are all on the same page. Education would include elements such as reassurance that symptoms can be expected to resolve over time, typical time and pattern of recovery, importance of rest as needed, physical and cognitive, gradual reintegration to regular ADL, and an opportunity to ask questions and provide feedback. Cognitive rehabilitation would include elements such as task management strategies, compensatory approaches to ADL, for example, a student attending class without note-taking. And last but not least, manual mobilization therapy, which is defined by the POC as passive movements of a joint within its normal physiological range. There is no mention of specific treatments such as craniosacral or massage therapy techniques, but as stated by Don and Steph last week, if a manual technique is within your scope of practice and you feel competent to administer it, and you feel that the administration of this technique will be in the best interest of your patient, then you should include that in your manual mobilization. You should include that within your treatment. The only non-recommended intervention listed is the prescription of pharmaceuticals, and this is not at all under our scope of practice, and it goes without saying that this would not be an intervention that we should be practicing in anyway. Again, along with the previously mentioned information, please find the algorithms, which is basically a flow chart of the treatments within the POC, of the MTBI POC, as well as the discharge reports on the website. The submission of the discharge report is absolutely crucial to the success of the demonstration project. One more time, for the project to have any measure of success and usefulness, a discharge report for each patient included in the demonstration project must be completed fully, appropriately, and be submitted. This can be done using the fillable forms on the OATA website and can be submitted electronically. The Rivermead Questionnaire and RAND 36 scores are to be entered upon assessment and upon the discharge report under the appropriate section as indicated.